Hi everyone, I'm Shoaib Ahmed, PCN clinical pharmacist. I'm pleased to welcome you to our Seacroft Primary Care Network podcast. It's a chance for you to meet the people involved in your care and to have an insight into how practices work together to create the network. Today we're meeting our clinical director, Dr. George Winder. Welcome to the podcast, George. Please could you start by telling us a bit about yourself?
Hi Shoaib, thanks for having me. So as you said, my name's George Winder. I'm a GP at Oakwood Lane Medical Practice, which is in Gipton. I've been working there for over 13 years now, so much of my career as GP has been spent at Oakwood Lane now. I'm from Leeds by background. I went to schools in Leeds, grew up in Leeds. My family are all living locally. So I very much see myself as not just a GP, but a citizen of Leeds and part of the family of Leeds. And that, you know, my two sisters both live here. My mum is getting old here. My great grandma still lives in Leeds. So the well-being of the people of Leeds is absolutely rooted within me and really important to me as a GP and as a citizen, really.
Please can you tell us a bit about your role as the clinical director of the PCN?
Sure, yeah. So PCN is a primary care network. So that's 4 GP practices in our area that come together really to help meet the needs of our local population. We roughly cover what we call the Seacroft area of Leeds, or more specifically, the area covered by those 4 practices. But the scope of the care we provide does reach out much further than just Seacroft as it's known. I guess my role within that is to support the growth of a primary care network. So we were just reviewing, it's only been 4 years since PCN started. We've gone from 0 to having a staff of just myself and a pharmacist to now having a staff of more like 20 in the space of those 4 years. We've gone from a range of services just offering some pharmacy support to a really broad spectrum of support that we offer patients and offer the practices. So our aim really is to keep the practices as connected as possible, to make sure that patients' care is as coordinated, as compassionate as possible. And in Seacroft, we like to talk about exceptional populations, so populations of people within Seacroft who need exceptional care, exceptional quality of care, but also exceptional in the way that it's delivered. So some groups of people, their care isn't suited to a traditional primary care model. So in traditional primary care, patients often need to come to the surgery, they get invited in or they make appointments, which we know can be a challenge for lots of people. And what we hope to offer as a PCN is really exceptional care to those populations of people where they can't access care in that same way. And we do that through what's called a population health approach. So we identify populations, and that can be geographical, but typically for us it's areas of clinical need. So people who might live in care homes, people who might have severe and enduring mental illness, people who live with frailty. All these people within these populations might need that additional support. So we use some data to identify how best we can help them. And then we make sure that we've got teams of people with specialist skills like yourselves to ensure that the quality of care that we provide to them is as good as possible, and that where necessary, we make reasonable adjustments and exceptional care for those people. For example, going into care homes on a weekly care ward round, people who have severe and enduring mental illness may need processes and reminders in clinical care that's slightly different from the general population. And again, we would look as a PCN to providing that.
Excellent. So what kind of challenges do people in the Seacroft area face, and how does PCN help to solve those challenges?
So I think Seacroft is a relatively unique area within Leeds. It has a great amount of strength, has a clear identity within itself, but part of that identity is no doubt that it's an area of economic deprivation, where poverty has a significant impact on people's well-being and their livelihood. We know that people in Seacroft die much younger than people in the rest of Leeds, so there's a premature mortality. We know that within that, lots of people who live in Seacroft live more years of ill health within that as well. So there's a huge health inequality for people who live in the Seacroft and surrounding areas. We know that poverty is the main driver for that. And so we understand that what we would call the wider determinants of health, things that affect people's health and well-being that sit outside access to healthcare, are the major drivers for this. So we know that 80% of somebody's health and well-being is contributed to by their wider determinants of health outside healthcare, and only 20% is their access to healthcare. So Seacroft PCN recognises this, and we work hand in hand with local partners. That might be third sector organisations, so charity and voluntary organisations that work with people, looking about things around, for example, cost of living crisis. For example, we know that there's high rates of domestic abuse suffered by people living in Seacroft, so we work with partners again about minimising the impact of that and understanding the effects that it has on people's health and well-being. We do work looking at fuel poverty. We look at work around warm spaces. We look at working with partners around what we can do really to minimise the impact that these wider determinants of health have on patients and people that we work with in Seacroft. What we recognise is that some of these challenges are better met at scale, and by that I mean at a single practice size, you might not have the specialist staff within that area, or that they don't have the time or space to provide services to these kind of exceptional populations, as we would describe them. And by working together across a larger footprint, so instead of working at a scale of 3,000 or 4,000 patients, we work at a scale of 30,000 patients. That enables us to have people and staff in place routinely who have a passion, an expertise, time, and that slightly different working makeup, so that they can really address people's needs as they need them. Again, that's not usually possible within primary care, within small GP practices to do this. So sometimes that is, and it's absolutely right, and it's better to be done at small GP practice footprint where you have that traditional beautiful model of primary care that where people are known from the cradle to the grave, as we describe it. But for some people that continuity is better delivered in a different way. So we're keen to continue to promote continuity. We don't want to take that continuity away from general practice and people's relationships with their general practice. But for example, if you're in a care home, you can acquire continuity with people during your time in that care home, which couldn't be done within a normal GP practice model. The same thing goes with people with severe and enduring mental illnesses. Again, continuity is absolutely key, and those relationships can be forged and established with specialist mental health workers. So we've been lucky enough to have specialist severe and enduring mental illness health worker whose expertise in health promotion and also managing and supporting people with severe psychiatric illnesses. The combination of that has meant that we've been able to really, really focus down on meeting their needs and developing a continuity and rapport with that patient that really supports them in that focused way.
Thank you for your time, George, and thank you to everyone for watching this podcast. If you enjoy watching these, then please leave a like and share the video, as it helps us to grow the channel and get more people viewing it. Thank you again for watching, and I look forward to you joining us next time. Bye-bye.